Good afternoon, everyone. I am Marcel Rodardi. As you all know, I'm the Executive Director for the California Contract Cities Association. I just want to say thanks for joining us. Before I hand it over to Paul to introduce Dr. Simon, I want to remind you that tomorrow is our third iteration of our virtual Sacramento legislative tour tomorrow at noon. We have Senators Portantino and Stern confirmed. We also have a very special message that was recorded for us by the governor, who is unable to attend in person, but they did send us a message that I received yesterday that we'll be playing at the end of the meeting. So please join us for that, for updates from our legislators up in Sacramento to find out what their priorities are for the year. And then finally, the next week after tomorrow, next Thursday, is our fourth and final iteration of our slot. We're working on confirming Lieutenant Governor Eleni Kalakanakis, and if you've heard her speak before, she's really, really great. She actually spoke to us last year up in Sacramento. Really, really great, great speaker, very informative. And then we have a couple of other legislators confirmed, and then we'll hear from, I think it's going to be Jason or Paul Gonzalez on sort of the tone of what's happening in Sacramento, what we can expect from this legislative session. And so with that, Paul, over to you.
Hey, thank you very much. The first meeting of 2021, it's got to be better. So happy New Year to the city manager group. Really happy to introduce today's speaker, Dr. Paul Simon. He's the Chief Science Officer and Director of the Division of Assessment, Planning, and Quality at the Los Angeles County Department of Public Health. He's also an adjunct professor in the Department of Epidemiology at the UCLA Fielding School of Public Health. Dr. Simon he's board certified in pediatrics and preventive medicine. He completed a 2-year fellowship in the field of epidemiology with the Epidemic Intelligence Service Program at the Center for Disease Control and Prevention. And that was back in 1992. And then he served as the medical epidemiologist in the CDC's Division of HIV/AIDS Prevention. He was assigned to the Los Angeles County HIV Epidemiology Program from 1992 to 1998. He joined the Los Angeles County Department of Public Health in 1998 as the director of the Office of Health Assessment and Epidemiology, and then served as the director of the Division of Chronic Disease and Injury Prevention. In his current position, he oversees the department's Office of Health Assessment and Epidemiology, the Office of Planning, Evaluation and Development, the Office of Quality Improvement and Accreditation. In his role as the Chief Science Officer, he leads the department's effort to integrate science into public health practices. He and his staff support efforts across the department in areas of evidence-based practices, program evaluation, public health surveillance, population health assessment, economic evaluation, and health impact assessment. And they perform other studies as well. As you can imagine, he's a very busy man, and we're very fortunate to have him on our call today. With that, I'm going to hand the screen over to Dr. Paul Simon.
Thank you, Paul. And I'm going to just pull up my screen here. Well, let's see. Okay, I think we're good. Well, I really appreciate the invitation to speak to you all today. And I'd like to move through the slides as quickly as possible, actually, to leave plenty of time for questions. So just want you to know I'm happy to share the slides with you afterwards. And let's just head into it. First of all, a disclaimer that the situation is actually evolving so rapidly that on any given day that I prepare slides and then plan for a presentation several days later, it's already outdated, and that's the case even with this one. So I'll highlight where there have been some updates. But for the most current information about our vaccination efforts, you can go to this website, vaccinatelacounty.com. For general information about COVID-19, there's another link, and then there's a specific link for healthcare providers as well. I think it is noteworthy today we're actually one day beyond the 1-year anniversary when we had the first reported case of coronavirus infection in LA County. It was a travel associated case. And then things were quiet in February, and in early March, we began to see additional cases with some that were clearly locally acquired infections. And I think it's worth just reflecting on the fact that in this single 12-month period, we've now seen over 1 million reported cases of COVID-19 in the county. And based on our modeling efforts here, we estimate between 3 and 4 million persons who've actually had the infection. So in other words, our COVID statistics are really the tip of the iceberg, and we believe about 3 or 4 in every 10 Angelenos have had the infection. It's certainly not evenly spread across our 10 million residents in Los Angeles County. We have some communities where probably it's more like 60 to 70% of all persons have had the infection, and other communities where it's only maybe 10 to 20%. As you probably all know, we've also seen devastating impacts in relation to mortality, with now over 15,000 COVID-related deaths. And just to put that in perspective, overall, we see about 60,000 deaths each year in the county for all causes combined. And so 15,000 just attributed to COVID is quite significant. In fact, prior to COVID, heart disease was our leading cause of death at about 11,000 deaths per year. So you can see the sort of the significance of COVID over the past year. And I share this table just to emphasize how important age is as a risk factor for severe COVID disease. So if you see in the column that says case rate per 100,000, what you see is that the highest case rate is actually in the 18 to 29-year-old age group. Then it slowly goes down with age, 65 plus, quite a bit lower. But then if you look to the far right, the death rate, which factors in not only the number of cases, but the size of the population of each age group, you can see that the death rate much, much higher in the 65 plus age group. And if we further broke that down to those 75 to 84, 85 and above, the death rate goes incrementally higher with each advancing age group. We also see great variation, as I mentioned, across communities. And if you lump communities together based on the level of poverty, so for example, if you just take those communities where more than 30% of the population is living in poverty, you can see that the mortality rate is 262 per 100,000. At the other extreme, in those communities lumped together that have less than 10% of their population living in poverty, it's 76 per 100,000. So what is that? Almost a 4-fold gradient across socioeconomic status. And we see that if, we do put out a report. In fact, I think there's a table on our website that shows the cities and communities with the highest case rates, highest mortality rates. And it really does demonstrate that the cities and communities with more poverty have higher rates. And we see also great variation across racial and ethnic groups, with the lowest rates among whites and Asians. The highest rate, this is maybe a surprise to some, but the Native Hawaiian Pacific Islander population, by far the highest mortality rate, the Latino population with the second highest, and that's been well reported. And then the African American population, not as high as some might think in LA County, but still higher than in the white and Asian populations. So, as you all know, I'm sure, we've just experienced a tremendous surge that is now beginning to come down. This figure shows the number of cases over time, the sort of the 7-day average number of cases over time. And we were doing quite a good job in LA County in suppressing spread of the virus through late last year. We did have a bit of a surge in the summer last year, which seemed very significant at the time, but in reality, it was still quite a bit better than most other jurisdictions across the country. But then, unfortunately, in November, all things went south very quickly. And I think there's been a lot of discussion about why that was, but I think one factor is that we had done such a good job, I think, of suppressing spread over time, that we still then had a very large vulnerable population, maybe 80–90% of the population that didn't have any immunity whatsoever. And once we hit November, the election, our sports teams doing so well, and the celebrations that went along with that, the holidays, Thanksgiving, and then on into December, the winter holidays and New Year's, all together, I think, resulted in much more social interaction, much more spread. And so we peaked at about 15,000 cases a day. In contrast, earlier in the year, we were seeing maybe 1,000 cases a day, 2,000 cases a day, but you can see very quickly went up to 15,000, and now fortunately is coming down pretty quickly. We're now down to maybe 6–7,000 cases a day. Similarly, our hospitals were in really very dire straits. We, for example, in early November, I think, had less than 1,000 patients with COVID hospitalized across the county in all of our nearly 100 hospitals. But rapidly that increased to a peak of a little bit over 8,000 patients hospitalized, and it was crushing and very frightening. In my view, the most frightening aspect of this pandemic, the fact that not only could people suffering from severe illness due to COVID not be guaranteed of the acute care that they needed, but people with other acute health problems, a heart attack, a stroke, any number of other medical situations that required urgent care might not necessarily be able to get in quickly. And fortunately now we are seeing a decline in hospitalized patients. We're down to about, I think, 6,000. So that's good news, but we have a long way to go to get back down to where we were in the fall, down below, again, 1,000 or less. Particular concern are the ICUs, where we don't have the ability to expand the way we can for overall hospital beds. And then mortality, as I mentioned, over 15,000 deaths across the entire year, but you can see a big surge up to over 200 deaths per day. And we are seeing now a decline, although we're reporting over 300 deaths today, 309 deaths, but that reflects some deaths that occurred over the past 1 to 2 weeks. If you look at the number of deaths actually occurring each day, we're now at about 150 to 200, which is way too high. It doesn't surprise us that it's remaining high while case rates are going down, because there is a lag between when someone develops the illness to when they become hospitalized and ultimately pass away. There's that lag of 2 to 4 weeks. So now I'm going to switch over and talk about the vaccines and our vaccination rollout. So I'm sure, as you all know, there are 2 vaccines that are approved. They have emergency use authorization from the FDA, the Pfizer vaccine and the Moderna vaccine. There are some other promising vaccines in the pipeline, particularly the Johnson & Johnson vaccine. I've been told they may share their data with the FDA in the next couple of weeks, and we could get an approval by late next month. And what's exciting about this vaccine is it only requires a single dose. The Pfizer and Moderna vaccines all require 2 doses, which really greatly complicates our rollout. AstraZeneca, I think, also very promising. It's a 2-dose regimen, but I've been told that we purchased a very large supply of AstraZeneca. So once that is approved, it may really help with our supply issues. It has been approved for use in the United Kingdom, and we're just waiting for results here. The FDA and their advisory bodies to determine if they can move forward. There's the Novavax vaccine, which is a 2-dose vaccine as well. These 3 vaccines are easier to manage than certainly the Pfizer vaccine, which requires the ultra low temperature refrigeration. That makes it very difficult to use the Pfizer vaccine in many different locations. But Moderna vaccine and these other three, I think, are easier to handle. This was well publicized information. It was actually quite a transparent process. Both vaccines that were approved were highly effective, much more so than any of us imagined they would be. 95% efficacy, which is unusually high for an RNA virus where you get lots of mutation. And in fact, the efficacy may go down over time as we start to see more variants appearing. Very importantly, the vaccine trials, which included together combined Moderna and Pfizer over 70,000 participants, they were able to include quite a diversity of participants across demographic groups, racial, ethnic, age, gender, also including people with chronic health conditions. And the vaccines seem to work very well across all of those groups. The vaccines also, importantly, have very strong safety profiles. There are some limitations, though, of any vaccine trial, including these. In these particular cases, there was only 2 months of follow-up after people were vaccinated. The trials only measured the effectiveness of the vaccines in preventing symptomatic disease. We still don't know for sure whether the vaccines prevent asymptomatic infection, although we're hopeful that the vaccines do. And then there were some groups that were not included in the vaccine trials. And lastly, despite the fact that there were 70,000 people, that's not a large enough size to detect rare adverse events. But I can say now we've vaccinated across the country more than 20 million people. And so that is enough power to detect rare adverse events. And we're not seeing any, with the possible exception of anaphylaxis, a severe allergic reaction. And we're seeing that about 1 in every 250,000 vaccinees. So it's quite a rare event, but important. It's treatable, and anybody who's delivering vaccine has to have the medications available to treat anaphylaxis should it occur. But just to underscore, that's a very rare event. So I'm now going to switch and talk about our campaign here. I know you're probably all very interested in that. And I won't go into the details here, but just to say that the phased approach is not something that we made up locally or even that the state made up. It really is based on guidance from the Centers for Disease Control and Prevention and their advisory committee. And it's a framework that was based on certain principles involving epidemiology, ethical principles, and some programmatic considerations. States and local health departments do have flexibility, though, to tailor the guidelines. And in fact, that's what's happening here in California. And I'll talk about that in a moment. And just to reassure everybody that we're working very closely with the California Department of Public Health on this. We want to be as consistent as possible. There's already enough confusion about one county doing one thing, another county doing a different thing. And it's, I know, very frustrating for the general public. So this shows the various groups included in the different phases. And all of this information is available on our website, vaccinatelacounty.com. And this slide, I put this together a couple days ago, but it is already outdated because the state has decided to move in a different direction. We're committed to phase 1, all frontline healthcare workers and long-term and residents and staff at actually all long-term care facilities. We're already well into this phase. It's an estimated 800,000 persons in LA County. We think that most in this group who want a first dose of vaccine have gotten it, and that many others have already gotten their second dose, and we're working hard to make sure they all get their second dose on time. We've moved into phase 1B, tier 1, just that top line, persons 65 years of age and older. That in LA County is 1.3 million people. So I just want to emphasize the importance of that large number. We're getting about 150,000 vaccines a week in LA County. And if we were, ideally we'd want to vaccinate all 1.3 million of these 65 and older folks. So that's 2.6 million vaccine doses required. It will take us about 4 months to do that, just that group, if we don't get more supply of vaccine. So we are urging people to be patient. We are hopeful that there is going to be more vaccine coming in next month, but we can't be sure till we see it. The state has also said that beginning in early to mid-February, they want us all to open up vaccination to this next group, in Tier 1, those working in education, emergency services, childcare, and food and agriculture. That's about another 1.4 million people in LA County. So again, it's a big number to deal with. And then beyond Tier 1, the state has decided we're not going to go based on these different essential worker groups. We are simply going to prioritize based on age. So the next group will be those 50 to 64. Once we've made some inroads with that group, we'll go down to 40 to 49. And in addition, the state has decided that they will coordinate the process, that it will no longer be sort of counties doing it at their own pace. There'll be a standardized process across the state in the rollout. So I've already alluded to much of this. I think the February outlook, slow pace of vaccinations will continue due to the limited supply, but there may be, a bit of an increase next month. We'll see. We are partnering to build an expansive network of vaccination sites that are safe and easily accessible. But here's the other big change that was just announced yesterday by the state. Over the next 3 to 4 weeks, they're going to be transitioning to a new system of distributing the vaccine across the state. To date, it has been the state working with each local health department to determine who gets what vaccine. And in some cases, the vaccine would go directly to those entities. In other cases, the state would deliver the vaccine to us, and then we would distribute it out to some of these entities. It's resulted in a very kind of fragmented, confusing, and inefficient process of distribution and delivery of vaccine. And so the state will be implementing a more centralized approach. They'll have what they're calling a third-party administrator. It will likely be some sort of large health plan or an entity that has lots of experience working with healthcare systems. And there'll be a statewide vaccine delivery network that will be primarily members of the healthcare system. It'll be hospitals, it'll be private healthcare systems and offices, it will be community clinics and federally qualified health centers, it will be pharmacies. We can talk more about this after my presentation, but I think it will have implications for how cities can participate. And I think there will continue to be opportunities for cities to take a very active role in this rollout. But I think it would be important for cities to partner with a healthcare entity in your city, or maybe several cities, work together to partner with a healthcare provider in your area to do this. And then we are also carefully monitoring the variants, as I mentioned, because the coronavirus is an RNA vaccine. I'm sorry, RNA virus. When it replicates, the RNA does make lots of mistakes, creates mutations that then lead to variants. And the concern is that sometimes these variants may have different characteristics. They may, for example, spread more easily, or they may cause more severe disease. So we're monitoring that very closely. So just where we're at with delivering vaccine, let me go to the bottom table first. It sort of shows you how many doses we're getting on a weekly basis. And as of January 18th, we're at 853,000 doses received. This week we received, I think, another 138,000. So we're close to 1 million doses received. I think that's a minimum estimate because it doesn't include a couple other channels through which vaccine flow into our county. There are these, what are they called? well, there are these entities, healthcare systems that have facilities across the state, multi-county entities, MCEs, like Kaiser, for example. They're getting their vaccine directly from the state, and then the Kaiser system delivers it out to its various facilities. And so we don't get the statistics, unfortunately, right now on how many doses our Kaiser facilities and other MCEs are receiving in LA County. In addition, we don't know how many doses the CVS and Walgreens pharmacies are getting through this federal partnership to help vaccinate people in long-term care facilities. But so we've probably received over 1 million doses. On the upper table or row, you can see as of January 12th, how many doses we administered, 525,000. And it's a bit dated, this number, because we think the best estimate of how many doses we delivered are based on a weekly survey that we do. And we repeated that survey on the 19th, but got data that was not completely accurate. So we've reframed our survey to get more accurate information. And that was administered, Monday. So we'll have updated results by Friday. My guess is we've reached probably around 800,000 folks with at least the first dose of vaccine. And this is just a map showing the various locations where vaccine is being delivered. It's again a combination of hospitals, community clinics, pharmacies, and some of these so-called pods, points of dispensing, megapods, the very large ones, and then some smaller ones. The point here, though, is that we have lots of different providers, close to 200. I'm a little worried, though, when we go to the state system of distribution, the state may want to reduce the number of providers and focus more on the high volume providers and those that we're confident can deliver the vaccine very efficiently, and very importantly, can then report back into the state systems in a timely way how many vaccines they've administered, so that we have accurate statistics. It has been a problem. Some of our sites have not been able to report data, and so the data in the state system is very incomplete. Let's see. We have till about 1 o'clock, I think. Yeah, I think I'm gonna. Yeah, I'm gonna move through. Yeah, I'm gonna move through these last slides really quickly, and just again, you'll have a copy of the slide set, and if you have any questions, you can feel free to reach out to me. So, as everybody knows, the 2 vaccines that are available, it's 2 doses. You should use the same vaccine for the first dose and the second dose. The first dose of the second dose of Pfizer should be given 21 days after the first dose. The second dose of Moderna, it's 28 days. But the CDC has said that you can actually go up to 42 days after. At this point, there's strong enough data to indicate the effectiveness if you wait 42 days. But we've been telling all of our vaccinating sites, 42 days is not the default. We're worried that not everybody who's gotten their first dose will be able to get their second dose in a timely way. So we want everybody to, all of these sites, to schedule second appointments for people getting their first dose, either 21 days or 28 days after that first dose, depending upon the vaccine administered. And that 42-day window is really a fallback for those that for whatever reason are delayed in getting or can't get an appointment for their second dose. It's not a default. If for whatever reason someone has an even longer interval between when they get their first dose and when they can get their second dose, be it trouble getting an appointment or just not wanting to get a second dose for whatever reason, even if it's 2, 3, 4 months of elapsed, they should still get that second dose, and there's no need to restart all over again with the first dose. As I mentioned, the vaccines so far appear to be very safe, very few reports of serious adverse events, but quite commonly there are side effects, and this is true of many vaccines, including these COVID vaccines. There, can be very often soreness at the site of injection, but also for a day or two, people experiencing fatigue, achiness, sometimes some fever and chills, but it's generally short-lived. And it's interesting, these side effects have been reported more often after the second dose than the first dose, and more often among young people than older people. And some believe that this reaction really reflects the body's immune system responding to the vaccine. So in some sense, it's good news. But for those of you who don't have a reaction when you get vaccinated, I wouldn't worry and assume that your immune system is not responding. Because again, we've seen a very good response to the vaccine. So if you've already had COVID-19, do you still need the vaccine? The answer is yes, you should get the vaccine. It will give your immune system an additional boost. But in conditions of severe shortage, I would say that if you've had documented laboratory confirmed COVID in the last 3 months, you can consider deferring the vaccine. You already have pretty good protection, but we're not mandating that at this point. It would be very hard to enforce that. If anybody who had COVID was treated with monoclonal antibody or plasma, they should wait 90 days to get the vaccine. There's been some reports in the press that possibly getting the vaccine could cause you then to test positive in the future for COVID-19, and that's not the case for both the PCR and the antigen test. It doesn't cause that. It is true, though, if you get an antibody test after being vaccinated, that would likely be positive. Because women who are pregnant or breastfeeding, I believe, were not included in the vaccine trials, we don't have any definitive data on efficacy and safety in this population. But so we do recommend that women who are pregnant talk to their healthcare provider. But there is no biological reason to believe, based on what the vaccine is comprised of, there's no theoretical reason to think that there would be a risk to pregnancy. But unless it's a very complicated pregnancy where a provider would be worried that their patient, even with fever, might go into premature labor, then you might want to hold off. But again, I think any woman who's pregnant has to balance the risks of COVID. And if with pregnancy is one of the risks for more so severe COVID disease if one is infected. So I think pregnant women should speak with their healthcare provider if they're concerned about the vaccine. People with a weak immune systems also were not included in the vaccine trials, except for those, I think, with HIV infection that had stable disease. Here again, there's no reason to think that people would be at any risk of an adverse event if they have immunosuppression. But there's no yet data to know how well they'll respond to the vaccine, how strong the protective effect would be. We're still recommending people go ahead and get the vaccine, but if people with weakened immune systems are concerned, they should talk to their healthcare provider. A lot of confusion about this. I worked at one of the pod sites last weekend, and there were a lot of people asking me, should I get the vaccine if I have a penicillin allergy or allergy to sulfa medications? And just to be clear, or food allergies, just to be clear, a history of general allergic reactions is not a contraindication to getting the vaccine. The only real contraindication is if you've had a prior episode of anaphylaxis, very severe, life-threatening allergic reaction to a prior vaccination, or any component of the current COVID-19 vaccines. And the only component that really seems to be allergenic is something called polyethylene glycol, or PEG. That would be a contraindication. Otherwise, people should feel comfortable getting vaccinated. If they have a strong history of other allergies, they can be observed for 30 minutes after vaccination. The routine period of observation is just 15 minutes. Again, of the nearly 1 million vaccinations that we've done here in LA County, we've not seen severe reactions. The entire day I spent at a megapod, I didn't see a single allergic reaction. I did see people that had other, I would say, more emotional or nervous system reactions. I saw several people that had severe panic attacks, and we were able to sort of help them deal with that, but no allergic reactions. If you should not receive another vaccine within 2 weeks of having received a COVID vaccine, even either before or after, because not that the vaccines will interfere with each other, but just that if there is an adverse reaction, we won't know which vaccine it was to. We don't yet know how long the vaccines will provide protection. As I mentioned, we don't yet know conclusively that vaccines prevent asymptomatic infection and risk of further spread of the virus. So we are urging people to, even if they've been vaccinated, to continue with the standard precautions, wearing a face mask when out in public or near others outside their households, and to practice physical distancing. And then there are a lot of myths out there about the vaccine. Some misinformation that is reasonable and easy to correct. For example, could I catch COVID-19 by being vaccinated? That's a reasonable question. The answer is no, that there's nothing in the vaccine that would, there's no actual viable virus or component of the virus in the vaccine. But there are lots of other crazy myths and just misinformation on the web. And we do have on our website, again, vaccinatelicounty.com, information about this to help counter this misinformation. And then sadly, there are also scams that we hear about. And it's important for everybody to know that the vaccine is free. People should not have to pay out of pocket. It's either covered by insurance or it'll be covered by just public dollars. Again, information on our website about that as well. I think I talked about this already. And we are monitoring very closely for adverse events. There are there's a federal system called VAERS, or Vaccine Adverse Events Reporting System, operated by the CDC and the FDA. And both providers can report, in fact, are mandated to report certain things, but also the general public. If you've had a vaccination and you've had an adverse event, you can report directly into VAERS. It's very accessible online. And then the CDC has created a smartphone or a smart device app called vSafe that anybody can sign up for, and they can report their adverse. And they will also receive messages from the CDC with information, and even if you've registered for the vaccination on certain sites, you even get reminders for when you need your second dose. So I'll stop there. Happy to answer any questions. And I can stop sharing this, I think.
Thank you, Dr. Simon. What we're going to do here, there's about almost 50 of us on the Zoom today. So if you have a question, please use the raise hand feature. It's down at the bottom under reactions. You can raise your hand, and then I'll try to go in order of the hands that I see raised, because I know there's a few questions, particularly from the city managers, as far as it comes. And I think Dr. Simon answered a lot of the questions when it comes to distribution of vaccine and the city's ability to institute their own program. So I'm going to start with Frank, since his was up first. Go ahead, Frank.
Thank you, Dr. Simon. This is Frank Cerruni, and I'm a council member in the city of Rolling Hills Estates. Thank you for coming, and we appreciate the information you provided. Suffice it to say that I think I speak for most of my colleagues that we are utterly disappointed and frustrated. I'm not going to talk about various levels of government, and I'm going to bite my tongue and not say more on that topic. But more importantly, I am going to say that the uneven distribution of the current vaccine over the county has been very disappointing to the South Bay in particular. Our folks on the Palos Verdes Peninsula in Torrance, Lomita, Redondo Beach have not had access as much as other folks in the county have had access to the vaccine. We know many people in the North County and Middle County and areas of downtown LA who have been able to be vaccinated in the category of 65 and up. We haven't had that. We have no access to it whatsoever. The closest to us has been El Camino College and the Forum in Inglewood. So how do you intend to remedy this so that we have access to it? I think, again, the state might be doing other things, but I think at the local level is the most important outreach that we can have. And our folks are utterly disappointed that they don't have access here. So can you explain, or can you tell us if there's any hope that we can see the vaccine in our area here, which represents several 100,000 people of the county?
So first, let me say I'm so sorry to hear that. And I know everybody 65 and older should have access to the greatest degree possible. I think we are hearing frustration across the county because the supply simply is not sufficient. But given that limited supply, we need to do our best to allocate it in an equitable way. So I think what we can do, I want to be clear that we are transitioning to a system where we in the county will not be dictating where the vaccine goes. It will be the state that decides that, and it's going to be primarily distributed through a network of healthcare providers. So I think it'll be really important to identify who those provider groups are in your region that you think would be most effective in delivering vaccine to your constituents. Now I know and I know Kaiser, for Kaiser members in the South Bay, I think you have had access through at least the same level of access that people in other parts of the county have had. For lower income folks in your region, I know Harbor UCLA has been vaccinating, so there should be access. But I completely agree with you with regard to the megapods and the pharmacy supply has been woefully inadequate. I've just heard repeatedly people can't get an appointment at the pharmacy. The pharmacies have very limited supply, so I know that's not sufficient. So in answer though to what can be done, I think I mentioned one thing, which I think is let's be very proactive in working with the state to make sure that we have healthcare providers enrolled in this statewide network that will serve your needs as well as the needs of others in the county. And then in addition, I don't think we'll be running these megapods, which has consumed a tremendous amount of resources. I think we can pivot to smaller sorts of pods and community events so we can have more of them. And cities, I think, can really take a leadership role in planning those. They'll either need to work with us, although I want to just emphasize we'll have limited supply. We'll be considered one of the providers, but we'll have limited supply and we have limited resources to run many, many pods across the county. But you can also work with your healthcare provider groups to operate those pods as well. So again, I do apologize. I know it's a very large population base there, and we'll do our best to try to remedy the inequities.
One quick follow-up on what you just said. We already have a plan at the local level. Who should our city managers here, Torrance, Lomita, on the Palos Verdes Peninsula, contact at the county to actually get doses? Because we do have a plan and we can immediately implement that plan at the local level, partnering with you. Who should we contact to get those doses?
So the lead would be D. Bagwell, the letter D, and then Bagwell, BAGWELL, at ph.lacounty.gov. But I just want to emphasize again, we don't have vaccine right now that we can just offer up. But she is working with a number of cities to, in fact, she works in our emergency preparedness and response division. And so she has a long history of working with cities to coordinate emergency response with cities. And so I think it'd be helpful to see your plan and then to prioritize as quickly as possible when we have available vaccine. But for the residents of the South Bay, looking forward, I think it will be important for people to recognize that most of the opportunity to get vaccine will be through their healthcare provider network. And that the community sites, pods and those sorts of things will be used to sort of try to fill the gaps.
Thank you, sir.
Thank you, Frank. John, go ahead.
Oh, yeah, thank you, Marcel. And thank you, Dr. Simon. You kind of answered my question just right now, and that was that will the new healthcare distribution sites be in addition to the county pods or in lieu of? So, but it sounds like they're going to be in addition to, and you're going to run some of the county sites still. Is that correct?
We hope, but all this remains to be determined. It depends what supply of vaccine we get. I know we're going to get some, but we don't yet know to what degree the state will allow counties to what degree the state will provide enough supply for counties to really, local health departments to really operate these pods. I think, yeah, there's a lot of unanswered questions at this point. I think strategically, the most important thing we can do is to make sure that we have a healthcare network enrolled in this statewide network that will best meet the needs of our constituents. So in your area, I'd want to know, where do most people receive their healthcare services? For example, what percentage are Kaiser members? What percentage, have other forms of private insurance that take them to different healthcare sites? The state's going to be prioritizing, I think, larger healthcare provider groups. So that solo provider, someone in solo practice probably will have a difficult time getting into this network, at least initially. We're happy to work with you, though, to figure out how we best strategize to meet the needs.
Okay, thank you.
Region.
Thanks, John. Go ahead, Greg.
Hi, Dr. Simon. This is Greg Grammer, City Manager for the City of Rolling Hills Estates. Thank you for being with us today and for your presentation. Can you talk a little bit about what role our schools and school districts throughout the county will be playing in the vaccine distribution? I know that there's been some talk at the Board of Supervisors level about including schools. Thank you.
Yes. So again, here, I think the announcement yesterday was really important, because prior to that, when we were really in charge of distributing vaccine, we have lots of communications with various school districts to work with them in a collaborative way, because some school districts actually, they have this, school-based clinics. They already have a healthcare infrastructure and they're used to administering vaccines. And so we would try to, particularly when we reach the point where teachers and other school staff are included, are eligible, we would have pivoted some supply to those school districts that are ready and could ramp up vaccination quickly to serve their employees. But I don't know yet how the state is going to view this. The sense I had in the call that we had yesterday is that they are really going to be prioritizing healthcare, the healthcare system. And so I don't know to the degree to which they will consider school districts for direct, receipt of vaccine versus, there's no question that we will support, we want to encourage partnerships between schools and their local healthcare providers. I've talked to some of the healthcare provider groups who've said, we're excited about being able to vaccinate, but we have limited space in our clinics. And we would be interested in partnering with a school or with a city to run some kind of a community site in a large parking lot, for example, where we could vaccinate a much larger number quickly. I know the Compton School District and St. John's, what is it called? Well, St. John's Clinic, it's an FQHC. I think they are collaborating in that sort of way, I believe.
All right, great. I don't see any more hands raised. Dr. Simon, I have a quick question. So one of the things that I've heard you mention is that most of the, particularly when we move into the broader range of folks that are going to be eligible for vaccinations, once you have those vaccines available, how will cities or how is the county going to work to get those that don't have healthcare vaccinated? Because we're talking about, healthcare centers sort of being the center. There's a lot of folks out there, particularly in less affluent communities, that don't have healthcare. What's the plan for the county? Is it just going to be like these sites, or like the CVS is going to offer free vaccinations to anyone who shows up?
Yeah, that's a great question, because we know there'll be a number of folks that fall between the cracks. And so pharmacies is one option. The Department of Health Services has a large ambulatory care network that can vaccinate those who don't have health coverage. Some of the network of community clinics and FQHCs can also vaccinate. But there may be some groups, for example, the homeless or agricultural workers are another population is going to be prioritized. It may be difficult to reach them in those ways, and we will have what we call strike teams that will be available that can be mobilized quickly and could go out to particular community venues. It would need to be a time limited kind of thing to try to get groups vaccinated that way. But it will be a challenge. We are working very closely right now with the homeless services providers to make sure that we have some mechanisms in place to reach that very large population.
So Marcel, I'm having difficulty raising my hand. I see Lindsay raised her hand. And maybe when she's done with her question, I do have a couple of kind of pivoting questions for Dr. Paul Simon. Really appreciated his presentation. It was, fascinating, really good intelligence. One of the things, though, when I did his introduction, I think I read epidemiology at least 10 times in his intro. And there seems to be some sort of competing discussions right now about the business closures and the impacts of that. So after my mayor asks her question, I'd like to just spend a few minutes just kind of talking about some of the new information that's being shared. I think there was a San Francisco Chronicle article, and there were a number of local articles on this particular issue as well. So why don't we hear the mayor first? Sorry, Lindsay.
Okay, great. As soon as she's done, Paul, we'll go straight back to you. So go ahead, Lindsay.
That's my city manager. That was my question. We have been hearing from our residents. They're excited about things reopening, but there's a mixed response. It feels sort of like it happened in an on-off switch mode, as opposed to, rolling things back out with more precise protocols in place. I think we're happy to see our economy reopening, but we also want to make sure that we're doing all the things that keep people safe. We've asked specifically, our city has requested from the county on numerous occasions, a better sense of, what kind of numbers are businesses seeing that require them to be shut down if there's COVID spread? Conversely, why would we continue to shut down business operations that have not reported any incidents of COVID spread? Now that we're reopening, maybe that later point is a little bit moot, but I think, we're at the local level trying to enforce protocols that we're getting from the county and the state. And, it gets pretty confusing when we can't definitively say at this threshold or for these reasons shutdown happens. And we also lose public trust that way. And so I am interested in your thoughts about that.
Sure, great questions. There has been a lot of confusion, and we will be issuing a new health officer order this Friday to align as much as possible with the state order. And so what that means is that, there will be some reopening, personal care, establishments, for example. And under consideration is also outdoor dining. There will continue to be sort of capacity limits on those various public venues that are open, various retail environments, for example. So those guidelines will be very clearly communicated and on our website. And I had the web link at the beginning of my presentation. There are materials for just about every sector that will define very specifically what the requirements are to operate. Now, with regard to decisions about when something is closed or not closed and what's the rationale, it is very difficult to attribute an infection to a particular location because someone who develops symptoms was likely exposed 7 to 14 days earlier. And so the vast majority of people, when they become infected, don't have any idea where they were infected unless it was through a social network, for example, a household member who had the infection and then it spread, or they were at some kind of a social event and there were other people there that they learned had infection. But it's very hard to attribute an infection to a visit to a store, for example, or a visit to a restaurant. And so we didn't make, and I know the decision, for example, to close outdoor dining was very controversial and it really upset a lot of folks. And we do understand the economic hardship, and we know there's a cost there, not just economic, but also from a health standpoint as well, just the stress of all of that. But that decision was made, I think, because we felt that when people are sitting together at a table eating and they can't wear a face covering, there is a greater risk of transmission. But I will say that's being revisited. I can't say for sure what the decision will be, but there will be a new health officer order out this Friday that will address outdoor dining as well as some of the other public venues. The goal here again is to make our guidance as consistent as possible with the states. And we do try to minimize changes as much as possible. When you face a surge, like the surge that we just had, which was devastating, it really then, requires us to make some changes. But now that we're seeing a downward trend, a positive trend, we do feel confident opening things back up again. But I will say we have to monitor this closely because we're really concerned about the new variants that are circulating, particularly the variant that originated in Great Britain that now seems to be here at a low level. But based on the experience in England and based on some modeling work that was done by the CDC, there is some belief that this strain could become the predominant strain in this country and including California over the next couple months. And that strain does seem to be transmitted more easily. So we're going to have to watch this closely, and there's we can't predict more than a few weeks in advance what's going to be required in terms of measures to stem the spread.
All right, great. Paul, go ahead.
That's a bummer. No, I think you addressed it. I think it's been a constant moving target because we're dealing with just the height of the crisis. And first and foremost, we appreciate everything you're doing. I think you heard from the group some degrees of frustration, and I think that we along the way have made some missteps, but I think everybody's heart and effort has been really true to the cause. And I want to thank you and everybody in your team for all the hard work you guys are doing. It's really an amazing feat. It's a unprecedented time, and I think that's been used, overused, but it truly is. And we also recognize too the impacts on the hospitals, and it was truly devastating. With that, as we look to reopen our businesses in a safe manner, we really want to try to find ways to keep them open and keep people safe. And I think the constant dialogue and improving protocols is going to be the key thing here. But once again, as we approach the end of the hour. I really want to thank you for your presentation today. It was super informative. You did a fantastic job communicating with us. And on behalf of all of the people on this call, I thank you.
Well, thank you. And I just also want to share my appreciation for all that you guys do. And I hear you loud and clear on the frustrations, and I'll do everything in my power to make sure that as we move forward, we are listening to you and taking into account your perspectives as we roll things out.
Yeah, we're a tremendous resource for you. Anything we can do to help, we're here for you.
Thank you.
Right.
Yes, thank you, Dr. Simon. We do appreciate your time. We appreciate all your efforts to get these vaccines out as quickly and as efficiently as possible. So you're free to go. I think we're done with the questions. I'm sure you're busy, and so I want to be respectful of your time. We have a couple more things to cover with the city managers. If you bear with us, we'll keep you on just as briefly as possible. First, I want to give an opportunity to Jennifer or Christine from the league. Is there anything that you guys want to discuss with the city manager group?
Thanks, Marcel. If you give me an opportunity, I'll update the group really quick. I won't take long, I promise. The governor's budget came out a couple weeks ago. If you guys saw, it was a record-breaking budget. There was an estimated $15 billion surplus, a windfall, if you will, that he wasn't expecting when he signed the budget last June. He's prioritizing funding for COVID-19 vaccine rollout, but unfortunately, he didn't include any money for local governments. So we are going to be advocating for that in this interim. We have a detailed breakdown on our website, but reminder, this is sort of a first pass at a state budget. Legislature will start having their hearings. They'll have their own proposals. We know budget hearings have already started, so that will roll all the way through the summer until they have to present a budget to the governor by June 30th. The legislature also reconvened. We've already seen some bills that were introduced that were carryovers and that died from last year. Some of them are very familiar, so they're nothing new. That we do know that there's some new bills on the horizon, especially around housing. There is a bill deadline on February 19th, and then hearings will begin in mid-March. So we'll have a better sense of the landscape of all the bills. Once those deadlines have passed and the bills start getting heard, we'll be working with all of you and working with the Contract Cities Association on taking positions and advocating on those bills together. So keep your eye out for that. And then finally, just on the federal front, now President Biden introduced his American Rescue Plan, which is his version of the stimulus plan. It does include, which is good news for us, $350 billion in funding for local governments and states, mainly for vaccine distribution and economic recovery. The devil really is going to be in the details. We're going to have to see what gets proposed and run through Congress. We are going to be advocating for money for all cities of all sizes, direct distribution to all of you without any population thresholds. And we're going to want to make sure that that money comes to you with no strings attached. We are hearing loud and clear the challenges you guys are facing and want to make sure that any money that comes down to you guys, that you can use it for revenue loss specifically. So we'll be working on that. And as we get some more details, and if we hear that there's something moving, then we'll make sure and get you guys involved and ask you to reach out to your congressional representatives. So that's it. Thanks, Marcel.
Thanks, Jennifer. And real quick, I just want to let you all know, in case you don't already, Jorge Morales, he's there with the glasses, kind of funny looking hair guy. We brought him on as a consultant. Michael Vuong left. He's now working with Edison International. So thanks for that, Haig. Jorge will be your point of contact for Contract Cities, all things legislative. If there's something that you have a concern with, or so there's a piece of legislation that your city is working on that's specific to your city, please reach out to Jorge. It's Jorge at Contract Cities, Jorge. And Jorge, if you would, please post your email and your cell phone number in the chat. So if you need that to get a hold of him, or shoot me an email and I'll make sure you get his contact info. And so, as I said, all things legislative, when we're working on it, he's going to be our go-to guy for that. So let's see, one final thing. I want to give you all an opportunity, because I know we do this. I know we're a little bit past our hour, but is there anything that any of you need from us to take back to either the county, the state? Are there any concerns, or is there anything you want us to look into that you may have had trouble tracking down or anything like that? Usually I know we kind of do like a round table. So I know everybody's kind of dropping off, but just real quick, looking around, I don't see anybody. I think Thaddeus is ready to go. Okay. All right, guys, thank you all for joining us. I promise to keep it within an hour. We'll see you next month, and we're going to talk about some budget stuff again. And so please, looking forward to having a continued conversation with you all. Have a great rest of your week and a great weekend. See you tomorrow.